Good evening, everyone, and welcome you all for today's Journal Club meeting. And I thank Dr. Kundavi and Dr. Sindhuja for making it possible and keeping it going. Okay. I thank Dr. Madhupriya and her team and Mr. Sudhakar Cholan and his team for their active participation in today's meeting. No? As we all aware, women with the decreased ovarian reserve, they form the expected poor responders during ovarian stimulation. So, one-fourth of our patients may belong to this category, and it will become it's a clinical challenge for the clinician to get at least one blast, no, to maximize the number of oocytes available for fertilization and to transfer at least one euploid blast. No, that is our aim for this group of patients. No, so there are many interventions are proposed, and let us listen to Dr. Madhupriya and her team regarding these individualized approaches at all steps of ART treatment for this group of patients. No? This brief introduction, I hand over the mic to Dr. Sindhuja and Dr. Kundavi to take it forward. No? Thank you.
Thank you, Sharad sir. Sindhu, please take over.
Okay, ma'am. Thank you, Sharad sir. Thank you, Kundavi ma'am. Good evening, everyone. So for the first half of the clinical journal, I'd like to invite our chairperson for the day, Dr. P. Arulmoli ma'am, who's the chief consultant at the Reproductive Medicine Prana Fertility Center, Dr. Kamakshi Memorial Hospital, Chennai. She's also the clinical director of APAAR Center for Fertility, Chennai, and former OBGYN, SRMC, faculty of OBGYN, SRMC, and Kasturba Gandhi College. And she has more than 2 decades of teaching experience to postgraduate and fellowship students. And madam is interested in poor responders, endometriosis, and male infertility. So I think we have rightly have you here, ma'am, for today's session. I kindly request you to introduce the expert and the speaker for today's session.
Good evening, one and all. And thank you, Dr. Sindhu, for the kind introduction. I'm really grateful for this wonderful platform. And I'm thankful to Sharad sir, NSR sir, and Dr. Radha, Kundavi ma'am also. To start the session, very warm welcome to the NOVA team for their enthusiastic participation in today's Journal Club session of TAPISAR. And I'm very happy to welcome Dr. Madhupriya, an erudite friend of mine. Dr. Madhupriya is a fertility consultant, and she's a chief consultant at Nova IVF. She's an MRCOG, adding to the credit. She is a gynec laparoscopic surgeon, and she has done her fellowship in reproductive medicine from the prestigious MMM. She's a clinical director and a senior fertility physician. She has so many awards and publications, which has been done in national and international journals like BJOG and IJCP. And she is a member of a lot of associations, and she's an active participant in every association. And her special interest being biological hire for poor ovarian reserve and sperm reserve patients and oncofertility. And once again, I welcome Dr. Madhupriya to this session. And shall we move on, Sindhu, to the topic?
Next slide.
Thank you, ma'am. Yes, ma'am. Today's topic, diminished ovarian reserve, as sir said, rightly said, it's per se, it's a very challenging situation for both the attending clinician and the patient. There are various therapeutic options, and to talk about the therapeutic management in these diminished ovarian reserve patient in an evidence-based manner, we have our speaker today, Dr. Hema, Dr. Hemlata. Can I have Dr. Hema? Do you have? Yeah. Dr. Hema has completed her MBBS from Stanley Medical College and DGO from IOG. And she had worked in government service for more than a decade. And she has done her ICOG certificate course in ART. She has worked in Srishti Fertility Center, and she is working as an associate gynecologist in Nova, Punamali. And waiting to listen from you an evidence-based approach of therapeutic options of decreased ovarian reserve. Dr. Hema, over to you.
Thank you, ma'am. And a warm good evening to one and all present here. I'm here to present the Journal on the Therapeutic Management of Women with Diminished Ovarian Reserve, a systematic review and meta-analysis. The topics of discussion.
Can you kindly share your screen,
Sure.
Dr.
Is it visible, ma'am?
No.
Is it visible now, ma'am?
No, no, doctor.
Ma'am, at first, please open the PPT, ma'am, and then click on share option, which is in green color.
We just tried. It worked well, actually.
We did it earlier.
Yes, doctor, we can see now. Please
Yes,
put it
ma'am.
on slideshow alone.
Yes, ma'am. Can I start, ma'am?
It's not in full screen, ma'am.
Yes, please. It's not in slide, Maya.
It's in slideshow.
Now, ma'am? Is it?
Yes, yes.
Oh.
But we are not able to see Dr. Hemlata.
Yes, sir, I will.
It's
Yes, yeah, you can go ahead. Yeah.
see.
Yes. Okay. The topics of discussion for today are introduction to the topic, materials and methods, results of the studies, analysis of the results, interpretation of the findings, and conclusion of the studies. Going on to the introduction, management of women with DOR in itself is a challenge, mainly due to the reduced ovarian response of these women to gonadotropin stimulation and reduced pregnancy rates as well, and therefore decreased ART prognosis in comparison to women with age-matched normal ovarian reserve. A recent meta-analysis even suggested
Your
women with
slide is
DOR
not moving. Yeah. Yeah.
A recent meta-analysis even suggested that women with DOR tend to have higher risk of RPL and reduced embryo quality. Although there were many therapeutic strategies that have been proposed, but all were with mixed results. And the previous systematic review and meta-analysis are conflicting and inconclusive, mainly due to the lack of clear-cut definition of the diminished ovarian reserve. This meta-analysis investigated many of the adjuvant treatment and protocols based on prosterodon criteria, as it had specified clear cutoffs more precisely than those proposed by the Bologna criteria. Materials and methods. Eligibility criteria were the studies which had a comparison of different ovarian stimulation protocols versus placebo or non-intervention in infertile women with DOR undergoing ART were chosen. The primary outcomes that were assessed were live birth rate, ongoing pregnancy rate. And if these were not studied, the secondary outcomes that were assessed were the number of oocytes retrieved, number of M2 oocytes, the clinical pregnancy rate, and the miscarriage rate. The search strategy was mainly based on the PubMed, Medline, Embase, and ISI Web of Knowledge databases that identify relevant studies published up to June 2024. The selection of studies, 4 reviewers independently evaluated titles and abstracts to select only RCTs published as full texts in peer-reviewed journals, only articles in which the study population presented diminished ovarian reserve with AMH less than 1.2 nanogram per ml and AFC less than 5, according to the Poseidon criteria. Case series, case reports, book, Congress abstracts were not included, and total of 12,747 articles were included. Titles and abstracts of 941 articles were scrutinized and 127 full text articles were assessed for eligibility. 92 RCTs and studies were excluded for various reasons, such as basal ovarian reserve in the study population was not available, or ovarian reserve was not comparable between the groups. Basal ovarian reserve did not fulfill the Poseidon criteria. studies did not involve women undergoing IVF or ICSI, or they lacked appropriate control groups. 35 RCTs were only included in the qualitative and the quantitative analysis. The following interventions were assessed, mainly 13 of them: DHEA, testosterone, high versus low dose gonadotropin, delayed start protocol with GnRH antag, letrozole, clomiphene citrate, dual triggering, dual stimulation, luteal phase stimulation, luteinizing hormone, estradiol pretreatment, and corifoliotropin alpha. DHEA, 6 RCTs investigated the role of DHEA, in which 25 milligram DHEA 3 times a day for 3 consecutive cycles was given before the IVF cycle. The pooled effect size was number of oocytes retrieved increased, but there was no much difference in the number of M2s or CPR or live birth rate and miscarriage rates, as shown in the following graph. We could see that the number of oocytes and the number of M2 oocytes probably increased in the was higher with the DHEA group, and the clinical pregnancy rate, live birth rate, and the miscarriage rates were all similar. Testosterone was investigated in 5 RCTs, and the results showed increase in the number of oocytes retrieved, CPR, clinical pregnancy rate, and the live birth rates. They used testosterone gel for 21 days before the start of OS, and 2 other studies, they were using the testosterone gel for 56 days versus 10 days versus no pre-treatment. And in another study, which is one of the recent ones, had 6 weeks of testosterone versus 4 weeks of testosterone with no treatment. And 2 of the studies revealed higher number of oocytes, higher number of M2s, higher number of live births, and ongoing pregnancy rates. As described in this forest graph, we could see the number of M2s, number of oocytes, the clinical pregnancy rate, and the live birth rate all were increased in the testosterone group. High dose versus low dose gonadotropin, 3 RCTs investigated, in which they found out the lower number of oocytes were retrieved in the mild stim group, meaning higher number of oocytes obviously were found in the retrieved in the higher dose. According to the graph, we could see there is low dose had lower number of oocytes retrieved, but the clinical pregnancy rate and the live birth and ongoing pregnancy rates were almost similar between both the groups. Delayed start protocol with GnRH antag. In the delayed start protocol with GnRH antag, ovarian stimulation started 7 days after the GnRH antag pre-treatment. This was mainly to counteract the heterogenic antral follicle responsiveness in women with diminished ovarian reserve and to improve the ovarian synchronization. 2 RCTs actually were revealed that higher number of oocytes were retrieved, but there was no difference in the clinical pregnancy rate or the live birth rates. Letrozole was investigated in 4 RCTs, but all showed similar results between both the groups. Not much difference between the study and the control group. Same with clomiphene citrate. 3 trials were investigated clomiphene citrate, but found similar results between both the groups. The results were all comparable in all factors. Growth hormone, 2 trials were took up growth hormone for investigation, and in one 2018 trial, they had sustained release of growth hormone 20 milligram 3 times before and during ovarian stimulation, which showed higher number of M2 oocytes with no effect on clinical pregnancy rate and the ongoing pregnancy rate. But when the growth hormone was given at a dose of 4, 4, and 2 international units for 3 successive days in a 2019 trial, they found all the parameters were higher in the study group, meaning higher number of oocytes retrieved, higher number of M2 oocytes, and the clinical pregnancy rate and ongoing pregnancy rate were all high in the study group. Luteal phase stimulation. This is based on the concept that follicular development occurs in a wave-like model, and that 2 consecutive rounds of stimulation is possible in an ovarian cycle. So this results in a retrieval of competent oocytes as compared to the conventional follicular stimulation, and stimulation was started 2 to 7 days following ovulation or oocyte retrieval. This study was conducted with Learser et al. Showed there was no much difference between the 2 groups. There were similar number of oocytes retrieved, M2 oocytes, and live births. dual triggering, one RCT was performed and they found no difference in the number of oocytes or M2 oocytes, and they found their live birth rate was lower in the dual trigger group. Estradiol pretreatment results were comparable between the two groups. Luteinizing hormone, two trials were conducted, and one trial had showed no difference, and the other in 2022, which is a recent one, showed a lower apoptosis rate, higher number of oocytes rate, but the clinical pregnancy rate was similar in both the groups. Corifoliotropin alpha, two trials were conducted, and in one, they found no difference, in which 150 microgram of corifoliotropin alpha is given along with 300 IU HMG daily versus 300 IU recombinant FSH daily. There was no difference. And another trial in 2020 showed higher number of oocytes and M2 oocytes, and ongoing pregnancy rate were observed. Interpretation of the findings. DHEA could increase ovarian response but cannot improve clinical pregnancy and live birth rates. Testosterone could potentially increase clinical and live birth rates in diminished ovarian reserve women. High dose gonadotropin increased the number of oocytes retrieved but did not translate to CPR. Advanced age women with diminished ovarian reserve need more oocytes to maximize cumulative live birth rates. Therefore, 2 consecutive rounds of ovarian stimulation, dual stimulation, could maximize the number of oocytes collected in an ovarian cycle, thereby reducing the time to pregnancy. Limitation of the study was the heterogeneity of the women involved, which was based on AMH and AFC, which was overcome by the Poseidon criteria, which had clear cutoffs for these values. The diversity of the protocols that were used in the ovarian stimulation in different studies were also a limitation. Conclusion, live birth rate and clinical pregnancy rate improved with testosterone supplementation. DHEA, testosterone, and high-dose stimulation improved the number of oocytes collected. Other treatments in the studies did not show much improvement in the ovarian output or pregnancy rate. Given the paucity of published studies, however, these findings should be interpreted with caution and warrant further investigations. Thank you.
Good evening, one and all.
Yeah.
Good evening to my mentors,
Yes.
Dr. Sharat sir.
Yeah, Hema, it
Dr.
was a
Kundavi
good,
ma'am.
good presentation, and she has done an in-depth study. Good, Dr. Hema.
Thank you, ma'am.
For your expert opinion, Dr. Madhu.
Madhu, I
Thank
always
you.
call her as the knowledge bank, no? Okay, Madhu.
Yeah, sir.
Thank you very much, sir. That comes from you, who were my mentors here,
Yeah.
and Ninga, Dr. Kundavi ma'am, all of you are here. So, of course, it comes from you all, sir. Thank you so much, sir. Very honored to be presenting in front of you again.
Thank
And
you.
this is a kind of summary of the a systematic review and meta-analysis of the study, sir. Next slide, please. So the critical summary of this topic, therapeutic management in women with diminished ovarian reserve, is based on the study by Conforti et al., which is published in 2025 Fertility Sterility Journal. Next slide, please. The overview of study, as we saw now, shows that the type of the study is a systematic review and meta-analysis of about 35 randomized controlled trial studies with good value. The population included were women with decreased ovarian reserve. According to the Poseidon criteria, no other criteria was taken into consideration. AMH of those women less than 1.2 nanogram per ml or antral follicle count of less than 5 were considered and included in the study, increasing the power of the study. Focus was on evaluating the adjuvant treatment which we are using during ART in such decreased ovarian reserve patients to improve outcomes. Next slide, please. Coming to the strengths of the study, they have followed methodological rigor properly. They have followed the PRISMA guidelines. PRISMA guideline is a kind of 27 set of items that needs to be followed for any systematic meta-analysis, systematic review or meta-analysis. And this study has been Prospero registered. Prospero register is a kind of international register where they actually register the study in order to avoid unwanted duplication and research waste is avoided. So these two have been followed, and integrity tool is applied and made sure that only those who rigorously followed the inclusion criteria were taken up for this study. Those RCTs which did not qualify the entry points were not considered. Second strength of the study was a well-defined population because they considered only Poseidon criteria to determine the decreased ovarian reserve. So this enhances the internal validity of the study. The third strength of the study is a statistical strength. The random effect model has been followed, and they have analyzed using intention to treat, and bias checks have also been done, which is mentioned in the study by itself. So random bias have all been eliminated. That gives a statistical strength to the study. Comprehensive scope of the study is that it has assessed nearly about 13 treatment strategies. We have a lot of strategies to treat reduced or decreased ovarian reserve, such as testosterone, DHEAS, high-dose gonadotropins, many more. All these 13 treatment strategies have been assessed using the single meta-analysis. Next slide, please. But the weaknesses of this study comes up when the PRP or the stem cell therapy, which is either the bone marrow aspirated stem cells or the peripheral stem cells along with the PRP, has not been used or studied. Now, the key finding of this study is that the testosterone is found to improve live birth and clinical pregnancy rate, whereas DHEA, delayed protocol, or high-dose gonadotropins have been found to increase the oocytes, but no pregnancy benefit has been observed, either in the form of live birth rate or clinical pregnancy rate. While letrozole use or growth hormone use or the use of LH or dual triggering, all these have not been found to have any significant clinical improvements. Next slide, please. So the limitation of this study is that there are differences in ART protocol, even in the drug dosages. For example, growth hormone, some of the studies quoted here, the RCTs have used 4, 4 and 2 units, and some of them have used a higher dose of up to 14 to 30 units. And the demography also varies because it is a multi-centric trial which has been done in some of the randomized control trials, and all of them have been considered for the systematic review and meta-analysis. So the differences in the protocols, dosages, and the demography leads to heterogeneity. And the study power is limited because there are many interventions, but each one of them have been backed by only very minimal number of RCTs, 2 to 4 RCTs for each of these. For example, DHEAS has some few RCTs backed up, and the growth hormone has some RCTs only backing up. So the study power hence seems limited. And restricted generalizability, whether we use the criteria used here for the study, it is only applicable to the Poseidon-defined poor ovarian reserve women and cannot be used if this criteria, Poseidon criteria, is not being applied. And the potential conflicts of interest exist because there have been some authors who have had pharmaceutical ties. Next slide, please. The conclusions and recommendations from the study that we could gather is that the testosterone shows the most promising treatment in improving the pregnancy outcomes in poor ovarian reserve women who are undergoing ART, IVF, or ICSI, and as suggested by Poseidon criteria. The recommendations would be further high-quality RCTs are needed. For each of the supplementation, there needs to be a backup by good quality RCTs to validate the findings and assess the interventions. The clinical decisions should remain individualized till then until we have stronger evidence backed up by good number of good quality RCTs for each of these recommendations. Thank you, Anna.
Excellent compilation of the results. And diminished ovarian reserve always is a big challenge, and it has to be individualized, as you said, and each patient requires different protocols. And maybe the first cycle when you do, it always happens to be a trial cycle, or You really have to counsel. So the basis of everything is counseling. This is what I feel. And in your experience, what about the testosterone gel, Madhu?
Ma'am, I have used testosterone gel, the Androtos. This gel, which we have used from day 21. A little different from what the study says, which says 21 days of the gel use in the luteal phase, but we have used from day 21 of the luteal phase in the pre-ICSI cycle. But because, as we say, we do not have a control to see whether it was only because of the gel that there was an increase in the number of oocytes, or it is actually the first cycle that we actually use this testosterone gel. We are unable to identify if it is because of the testosterone gel use that they have actually increased the number of mature oocytes. But we have had a few cases where the first cycle, when we do pooled ICSI cycle, when the first case do not give of poor ovarian reserve, do not give good number of oocytes, mature oocytes, we do try with testosterone gel in the luteal phase of the second cycle. And on the third cycle, we start from second or the third day of the third cycle, we start the second ART cycle. So there, the first cycle of the same patient acts as a control for the second cycle with testosterone gel. A few of such cases have shown not a very significant increase in the mature oocytes, but the live birth rates have been better.
Do you have any side effects or any limitations for testosterone gel?
So far, no. So far, no. We've been using only a single dose of the gel or the testosterone gel per day. Not a very higher dose, though.
12.5, you mean? Is it?
No, ma'am. This comes in 5. This comes in 5 grams.
The sachet you're talking about?
The
Now it has
sachet,
come
the
with
gel.
accentuation. No, okay. It has come with
I haven't
accentuation.
used that, ma'am.
Okay, fine. So you were talking about pooling. Do you strategize pooling right from the beginning or even before? Because that needs what I said, counseling. So,
Yes,
or you decide on the oocyte quality, and how do you counsel the patient regarding outcome of pooling an oocyte or then an embryo?
There are 2 types that we divide it into, either a decreased ovarian reserve or a poor ovarian reserve. And then we have poor responders who we will not be able to identify all the times. So if the woman is anytime more than 35 years of age, previous ICSI failures, we've got a very low AMH and a very low antral follicles when I see them on the second or the third day, then I do counsel them that during the first cycle, let us see how it goes. How many number of follicles are there? So how many would be empty? How many would contain oocytes? How many would be mature? How many would become embryo depending on the semen quality and the quantity? And how many would grow well without any cleavage arrest until the day 5 or day 6 status is something which I counsel them. And in case it is going to be less, like 1 or 2 embryos, there are 2 options given to them. Either they go ahead with the available good blastocysts and see if they have their success, or they can go ahead with pooling of embryos with the second cycle. And we do give a gap of a month if necessary, for example, in the poor ovarian reserve patients, to use DHEAS or testosterone gel, and sometimes growth hormone during the cycle to see if there is any difference between the first cycle, which itself acts as a control for the second cycle during the pooled ICSI cycles.
Growth hormone, you start from day 2, 4 milligrams.
From the day 2 or day 3, whenever we are starting the stimulation, 4 units is used, ma'am. Of course, scientifically, they suggest you can use up to 32 units, international units per day, but we use a very minimum of 4 international units after appropriate checkup with the growth hormone levels and the X-ray skull if needed.
Very basic question. Very low ovarian reserve. In Poseidon 3, you keep maybe less than 35. And there are only, how do you assess the ovarian reserve? Depending on what will be your prime criteria to assess the reserve?
Prime criteria is an antral follicle count, ma'am. If it is going to be anything less or high, for example, hyperresponder kind of a picture, PCOM kind of a picture, or very less number, less than 5 to 7, then I cross-check it with the AMH levels.
Does AMH correlate?
Most of the times, yes, ma'am. If it is in a properly done lab and it is a proper 3rd generation assay, it does correlate. Of course, AFC which we do on our own gives a better identity rather than the AMH levels. But the standardized assays of AMH in the recent days have been able to give us a good idea.
I think AMH, Dr. Arulpriya, I think AMH will be a better this one than compared to antral follicle count. No? Sometimes there will be about 4 or 5 follicles will be there. When you start with a high optimum dose of gonadotropins, only 1 or 2 will start developing. No? So in that particular scenario, I think AMH will give a better idea than the antral follicle count, I feel, Dr. Madhu. I don't know whether you agree with me or not.
Correct. So for poor responders, we definitely need to correlate with the AMH. Sometimes it helps. Yes, sir.
Madam Kundavi, madam, you wanted to
They were
say?
just saying about high dose gonadotrophins, right? So what do they mean by high dose? What is the maximum dose do we really give? Because in one paper they said, higher dose has got increased risk of aneuploidy, but now I think this recommendation is the poor responder high dose. So what is your high dose, Madhu?
Ma'am, 300 to 450 is suggested in the scientific studies. As far as I'm concerned, 300, ma'am. We have followed up to 450, not more than that. Some trials have taken it up to 600, but beyond 450, most of the times the aneuploidy rates are more. Until 450, not much of a difference between 300 and 450 are seen. That is the high dose gonadotropins they've talked about in these trials, ma'am. And the low dose one is people using 150 or 225, 150 supplemented by 75 units during the stimulation, the milder kind of stimulation that they use for the decreased ovarian reserve. Now, with many papers coming up, people have started giving up on that mild stimulation protocol because the number of follicles required, the number of mature oocytes required to produce one euploid blastocyst to produce a pregnancy is seemingly very high, somewhere ranging from 30 to 50 oocytes. So now most of us, I think we are going towards the GnRH ANTAC protocol, standard COS protocol for even the poor ovarian reserve patients, ma'am.
Dr. Kundavi, I think 300 IU will be the optimum dose. No? I think more than 300 IU, most of the times we will be satisfying ourselves with the higher doses like 450 and 600. No? But most of the times they'll end up in the poor response and poor outcomes, I can say.
Sir, on one paper, they say recombinant gives an increased number of oocytes.
Yeah.
But a few studies suggest that you use a combination of FSH and HMG in the case of poor responders. What is your take home? What gonadotrophins would you prefer in these people?
Ma'am, as far as I'm concerned, the recent trials have come up saying HMG, HP, the highly purified HMG or HMG per se is equal to that of the recombinant FSH. So LH supplementation, maybe our LH supplementation to either of these two in those who are more than 35 years of age and those who have had a previous poor ovarian response in the properly stimulated cycles may help. So I would go ahead with both as equal yet, ma'am. The take-home message is both of them are equal.
But according to Humaydan, he did a RCT where he used recombinant FSH with recombinant LH from the starting of this stimulation, and he could find better results compared to other protocols.
Yes, sir, but most of the studies have said comparing our LH supplementation, it is helpful, but whether we use our FSH or HMG or HMG HP, they do not have much of a difference. Our LH supplementation makes a difference, they say, sir. So comparing, madam asked about FSH recombinant and HMG, whether there is any difference. Personally, and with the statistical reports, we haven't seen, sir. Yes, sir. But Humaydan sir has obviously had many papers which he supports recombinant FSH and LH combination for poor ovarian reserve.
That is expensive also, right? When you give a recombinant LH.
Yes, ma'am.
So probably something like Pergoveris, where there is a combination of FSH and LH, I think people have started using it in poor responders. I do not know because personally I don't have experience, but I'm sure most of them have started using it.
Can I add a point here?
Yes, Radha.
Yeah, we have used in a couple of patients this recombinant FSH-LH, that is a Pergovris. The advantage is we have a ratio of 2:1, which is being maintained. So we have got maybe in a small number, we have got good number of oocytes. I'm saying which is comparable, but to reduce the cost in our routine practice, we are using 300 of recombinant FSH and 150 of HMG. So because advanced maternal age and previous failures, there is a recommendation also you can give low dose of LH component. So for the cost factor, we are using HMG also along with the 300 of recombinant FSH. Fairly, we are able to get good number. And one more thing we are following is we delay the trigger 1 day later so that the dominant follicle crosses at least 20 millimeter and the other cohorts are somewhere around the 18 or 17 millimeter. So delaying the trigger by 1 day, it also improves the number of oocytes retrieved. That is what we follow. We have published that in International Journal of Fetal Medicine as well.
But
Yeah, I agree with you, Radha. We use recombinant plus HMGs.
Yeah,
And I
we
know
use
Dr.
that.
Elisa told us once, you will have that second cohort of follicles, like that
Yes.
15, 16. So if you can delay by 1 day or something, you can get the other group of follicles. So
That is the protocol we are following routinely in our
But
practice.
one thing, Dr. Radha, we had few patients where when we waited for a day, she went in for ovulation, even though she was on antagonist down regulation, but still she ended up in ovulation loss. We lost the
if
oocytes.
there are only one or two follicles, then we are little, we have to be careful. But when you have some cohort of like an intermediate, as Dr. Radha said, waiting for that 1 day, we could pick up the other group of follicles because people say even up to 2024, we can still wait for the
So
oocytes.
when we have doubt, we do measure the serum LH levels in those cases. And we are giving ganirelix instead of cetrorelix in that situation also. So it's just a trial and error combination. But delaying 1 day, we are able to get additional 1 or 2 sites extra. So that benefit is there.
Good, good.
But
Is
routinely,
there
we
a
use
role of
ganirelix or cetrorelix rather because ganirelix has got a long half-life, no?
Yeah, it has a little longer half-life, so we prefer in a DOR or if the LH level is raised. At times, we routinely in DOR patients we measure serum LH. So by afternoon we get the report, so we call them and give a second dose of anta also, like a cetrorelix. If we are giving before the trigger, we are giving a second dose also if the LH is high. So so we are delaying in that way. We have found a good response in that. So we did a study where we compared when we are giving a trigger at 18 millimeters and 20 millimeters in poor, normal, and hyper responders. We found it is of not much benefit when you are giving it in a normal or a hyper responder, but poor responder definitely it has a role by delaying 1 day. So that is a published article also.
Suppose you give the cetrorelix or ganirelix in the night. What about the surge, Radha, just before the trigger?
Normally, we are seeing this LH surge. We are measuring the LH in the morning. By 3 o'clock, we get the report. So we call the patient and give them by 5 or 6 o'clock another dose. And 3, 4 hours later, only we are giving the trigger. Most of the time, we are not combining both together. A small gap is there. Now we have started doing with the oral anta also instead of giving injectable. So here also we are measuring, but it is still in the infant stage. So probably after a couple of months, we will be able to get the data. We are measuring the LH level there also, not much of elevation. We are giving twice daily the dose.
Dr. Radha, for our patient who has ovulated, I did estimate the LH, but LH was within normal only, but I don't know what happened to the follicles. No? I couldn't explain why it has ruptured. So LH was
These patients have a premature, the short cycle, no? So even with the LH is not there. But my patients all had an LH was quite high. So I knew the next day when I brought them to see if the follicles were intact, the follicles had ruptured. So that
Yeah.
one of the patient even questioned saying that, Madam, you could have triggered me a bit earlier. Having spent so much, only 2 follicles, so I couldn't do anything. So I converted into an IUI cycle.
Okay. Is she conceived?
No, sir.
In diminished ovarian reserve, do you, in non-iatrogenic causes, in very young patients, do you consider receptor polymorphism something to be done? Do you do any, Kudavi ma'am, Radha, and you?
Earlier for the
It is not
students,
that
they
easily
use the
available to
receptor.
check the polymorphism. We did a study also. We were sending the sample to Vizag and we were analyzing it, but practically it is still not possible. So probably we may have to increase the dose even if there is a polymorphism. So for benefit of doubt, we are giving them a slightly higher dose and going ahead.
This is for the first cycle you're saying. I'm just asking
Not the first
even
cycle,
before.
not the
No,
first
it is you have a cycle, a trial, maybe it is a previous cycle. So you follow in the second cycle, you increase this. No,
Yeah,
I'm
second cycle.
asking,
The
is there?
first cycle, it is very difficult to say in the initial stage itself in a young patient that she's going to have a decreased response. So probably in those cases.
No, it is a diminished ovarian reserve in a young patient. There is 2 to 3 follicles. In a really young, in a non-iatrogenic cause, you don't find, and no family history of this. This is to just, there are evidences saying that receptor polymorphism will be affecting. Do you counsel or how do you go about it?
No,
You
we
just go
don't
with the
do it in the
stipulation.
initial stage itself. We initially, rather, we prefer to do a karyotyping for that female.
Yeah.
And we counsel her that one positive factor is the age. Even if we get 3 or 4 oocytes, the age is a positive factor. So in that way, we counsel and we go ahead. We first itself, we are not doing polymorphism testing routinely now. We did for almost a few, I think somewhere around 70 to 80 patients. So we had increased the dose of gonadotropin there. That's all. So we didn't do that. We are not doing it routinely.
But I don't think polymorphism is common in this group of patients where the decreased ovarian reserve is the problem here. I don't think pleomorphism is the
Yeah,
one
you
of the
could
reasons for
suspect
this.
polymorphism in a patient like
Where it's
Posidon group
normal
1.
ovarian reserve,
Yeah,
we can
Posidon
suspect.
1. In those
Mm.
cases, that will be the commonest cause rather than DOR directly.
Poor ovarian responders.
Yeah.
Yeah, yeah. Posidon 1 only should be considered.
PCO group tend to have the receptor polymorphism. We also did a study for the fellow's sake, and then Dr. Verma asked me one question. What do they tell you? Increase the dose. Then why are you doing this test? Don't waste the money. Just go ahead and increase the dose. So this was a lesson we learned. So we stopped doing the receptor polymorphism.
Yeah, that's what we just increase the dose in those patients. That's it.
Dr. Radha, in this case, a poor responder is either short flare-up, ultra flare-up protocol. Does it help?
No, now we are not doing all those protocols, ma'am. Either we have to go with an antagonist protocol or a long agonist protocol. We don't do nowadays flare protocols.
Most of them were saying that long protocol really helps the poor responders, but
Yeah, because the synchrony of the follicles will be better in those patients. So many of the recent papers are saying that you can go for a long protocol, and but still,
But then you need to have more of a stimulation, isn't it? If you go for long
yeah, the dose
protocol.
of gonadotropin, the number of days might be more, but you get a good quality of the oocyte and synchrony of the follicles will be better when compared to anta.
And also you can avert these ruptures if you had in premature
Yeah.
ruptures.
Thank
I
you,
think so.
ma'am.
Mr.
Ma'am?
Sudhakar is getting restless.
Oh no.
Yes, ma'am.
move on to the next one.
Shall we move on, ma'am?
Yes, Sindhu. Sorry about it.
No.
Yeah.
Thank you, Arulmoli ma'am, Madhupriya ma'am, and Dr. Hemlata for the excellent session. Thank you, Bharat sir, Radha ma'am, Vijay ma'am, Kundev ma'am, everyone for the inputs. For the next session, I'd like to invite the chairperson, Mr. Siddhartha Cholan sir, who's the embryology lab director at Aishwarya Fertility Center, and he's the course coordinator at EAI, an alumni of SRMC. He's trained at NIFHW New Delhi and Gleneagles, Singapore, and he's an executive committee member of TAPISAR 2022 to 2024, and he's re-elected this time 2025 to 2027. I kindly request you to introduce the expert and speaker for today, sir.
Okay, thank you for a kind introduction, Dr. Sindhija. It's a pleasure to introduce Dr. Sujata Madam. Madam is American Board of Bioenergy Certified in Embryology Lab Director in NOVA. Then hold position of IVF Lab Director in British Hospital, Abu Dhabi, Craft Hospital Research Center, Kurunganallur, and Cloud9 Fertility. More than 25 years of hands-on experience in clinical embryology. We welcome you, ma'am. So today topics we are discussing about the association between decreased bone reserve and poor oocyte quality. Then speaker is Mr. Raju Priya Pandian. We are pleasure to invite Ms. Raju Priya Pandian, who is a lab manager in Nova IVF Fertility, Annanagar, Chennai. Field of interest is male infertility, then time-lapse technology, and artificial intelligence ART, and special achievements in S3 certified embryologist and IFS certified embryologist. We are welcoming ma'am once again. Okay, kindly tell me your experience in the in the poor quality research. You're welcome.
Thank you. Thank you, Sudhakar sir, for a lovely introduction. And thank you, TAPISAR, for this opportunity to share the knowledge. I would like to share my screen now. Are you able to see the screen?
Yes, ma'am.
Okay, sorry, I'm somewhere in the middle. Okay, today I'm going to speak about the association between the decreased ovarian reserve and the poor quality oocyte. And according to the American College of Obstetricians and Gynecologists, the fecundity of women decreases gradually but significantly from the beginning of approximately 32 years of age, and it rapidly decreases when the female is around 37 years. And according to the ESHRE guidelines, premature ovarian insufficiency is a clinical condition by the loss of ovarian function indicated by irregular menstrual cycle together with biochemical confirmation of ovarian insufficiency before the age of 40. So I came across a lovely paper regarding the potential factors which result in diminished ovarian reserve. So I just thought of sharing it. It's from Zhu et al. And the quantity of oocytes stored in an ovary or the number of oocytes that can be recruited in a particular cycle could be defined as an ovarian reserve. And the decrease in the number or quality of the eggs in the women's ovaries lead to the reduced ability for them to conceive. And the main cause of decreased ovarian reserve could be primarily the age factor. That is what is defined in most of the journal articles. Hormonal influence could be AMH, FSH levels, LH levels, estrogen and progesterone levels, inhibin on androgens, etc. And could be due to metabolites, initial ovarian reserve itself, by birth, environmental problems, autoimmune diseases, and certain medications like medications relevant to cancer that could also lead to decreased ovarian reserve. So when it comes to primarily the age factor that has been defined in most of the studies, what would does an young age patient have a better oocyte quality? So in this interesting article, which is which studies the association between the decreased ovarian reserve and the poor oocyte quality, is what I'm going to discuss today. So this is the study design. It is a single center study conducted in controlled ovarian stimulation patients who have come for IVF in Curitiba, Brazil. And the period of study which has been included is from May 2012 to June 2016. And this was ethics committee approved by the Federal University of Parana. And the age group considered here were all age group above 18 and below 35 with or without previous ART attempts. So the exclusion criteria were females who were taking hormonal contraceptives or had HRT use 30 days prior to the assessment of the ovarian reserve. And women with the following history like pelvic radiology or chemotherapy, oophorectomy or oophoroplasty, and any endocrinopathies like PCO, hyperprolactemia, hypopituitarism, or autoimmune diseases were excluded from the study, and also those with genetic diseases which have been confirmed previously by karyotyping. And incomplete medical records like missing examination results, those medical record patients were also excluded from the study. So, material methods on day 2 or day 3 of the menstrual cycle, the venous blood sample was taken, and FSH, baseline FSH was determined by the chemiluminescence Illuminate 2000 XPI, and AMH was determined using ELISA, and AFC, the sum of the number of follicles in both the ovaries between 2 and 8 mm in both the ovaries were assessed by a single observer on day 2 or day 3 of the menstrual cycle using a transvaginal ultrasound. So the variables studied here were FSH, AMH, and AFC. In the control group, the normal range of FSH was considered, baseline FSH was considered below 10 milli-IU per ml, and anything beyond that was considered in the decreased ovarian reserve group. And in AMH, more than 1.2 nanogram per ml was considered the normal ovarian reserve group, and less than 1.2 was considered as the decreased ovarian reserve group. And when it comes to AFC, anything equal to or more than 10 was considered in the normal group, and the decreased ovarian group was anything less than 10. So in this controlled ovarian stimulation protocol used when it comes to gonadotropins, Puregon, Gonalef, Fostimon, and in HMG, Menopur were used. And the dose was fixed. Either it will be an FSH or an HMG, and the dose was between 150 and 300 IU, and this dose was determined dependent on the patient's age, AFC, and the number of follicles expected. And the GnRH antagonist orgalutron was used, and this was started when the follicles were more than 2 follicles were more than or equal to 14 millimeter. And the trigger was given when 3 to 4 follicles reach size of more than 18 millimeter. So for trigger, it was either urinary HCG, Corrimon, or recombinant HCG, Ovitril was used. So the dosage was fixed, and FSH was replaced by an equivalent dose of HMG from the 6th day of stimulation, but the units didn't change. So if 50 units of FSH is being replaced, it will be like 50 with the 50 unit of HMG. So from the beginning till the day of trigger, the dose was kept constant. So oocyte assessment, when it comes to oocyte, the maturity was assessed, and when it comes to oocyte morphology, the shape, the abnormality in zona pellucida, abnormality in perivitellin space, which included the changes in the polar corpuscle, and also any abnormality in the cytoplasm was observed. So these are the statistical analysis used. Student t-test was used for independent samples when they compared age versus the dose of gonadotropins. The Mann-Whitney U-test was used when number of mature oocytes and basal FSH levels were compared. AMH, AFC, and basal FSH group comparison was also done by Mann-Whitney U-test. Spearman's correlation coefficients was used when gonadotropin dose versus number of mature oocytes were compared and studied. Univariate multi-level logistic regression analysis was done when it comes to patient and oocyte related variables. A hierarchical structure was defined considering oocyte as level 1 and the patient as level 2. The Walters significant assessment was used with P less than 0.05. Association was expressed in either odds ratio or with representative 95% confidence intervals. And the STATA V14 software was used for data analysis. So the results in the whole study, the number of patients who underwent the controlled ovarian stimulation during the study period were 534, And the patients were excluded via age criteria when it is more than 35 was 182, and they did the patients who did not meet the clinical inclusion criteria itself was 259, and 44 had incomplete medical records. So a total of 49 patients with 348 oocytes were analyzed in this study, and the infertility causes severe male factor was 34.5% and the ovulatory factor was 14.3%. So most of the characteristics of the women included in the study is shown in this table. The age was plus standard deviation was 31.1 plus or minus 3, and the BMI was 23.2 plus or minus 2.5. So this is the patient distribution between the NOR versus DOR. The patient distribution as normal ovarian reserve or decreasing ovarian reserve differed as per the FSH, AMH, and the AFC measurements. Some patients could be under DOR category according to one or more of the ovarian reserve measurement study. So if you see the patient distribution, if we consider FSH as the criteria, 9 patients fell under the DOR category that accounted to 18.4%. Under AMH criteria, less than 1.2 nanogram per ml, 19 patients fell into that category, accounting to 38.8% of the study group. And when it comes to AFC less than 10, 23 patients were included in the study, accounting to nearly half, 46.9%. So the association between the FSH and AMH and the AFC, though the FSH was higher in DOR in both the AMC and the AFC groups, the mean FSH in both DOR groups were lesser than the cutoff defined for the study. If you see in the DOR group in AMH, the mean basal FSH levels were 8.8 versus in AFC DOR group, the mean FSH value was 8.5 plus or minus 3.3. So the risk of immature oocytes when it comes to AMH and FSH. The decreased ovarian reserve by AMH, the odds ratio of having immature oocytes by AMH is 3.3, confidence interval 1.2, 8.8, and that has a significant in the statistical analysis as well. In the decreased ovarian reserve by FSH, the risk of having an immature oocyte is 4.4, 95% confidence interval, and p-value of 0.023. Every unit increase of baseline FSH increase the likelihood of the patient having an immature oocyte by 23%, according to this study. So oocyte abnormalities associated with DOR. Patients with DOR had 5.3%, 3 times more risk with the presence of changes in cytoplasm of the oocytes rather than compared to the normal ovarian reserve patients, of odds ratio 5.3 and p-value of 0.004. The decreased ovarian reserve associated with AMH group less than 1.2 nanogram per ml presented more risk with respect to perivitellin space alterations, and the risk ratio being on confidence interval 95%, odds ratio 3, and p-value of 0.018. Decreased ovarian reserve patient under AFC group category, more abnormal shaped oocytes risk was observed with an odds ratio of 2.9 and p-value of 0.035. The alterations in zona pellucida versus the ovarian reserve and also patient age versus the observed oocyte parameters did not have any statistical significance. So this is the oocyte abnormalities which was studied in this category. Oocyte maturity was seen, the abnormal shape of the oocytes, the abnormal zona pellucida, the abnormal perivitellin space, and also the abnormal cytoplasm. So women under the age of 35 undergoing controlled ovarian stimulation in the DOR category exhibited poor oocyte quality, immature oocytes, and also alterations in the oocyte morphology. High number of immature oocytes and abnormal oocytes were seen in DOR in AMH group, even if they fall under the NOR category with respect to FSH cutoff, indicating that the baseline FSH alone might not be a good indicator of the oocyte quality, rather a late marker of ovarian reserve as illustrated by Wallace et al. In 2010, ASRM committee with respect to ovarian reserve in 2015, and also the ESHRE guidelines in 2017. The AMH and the AFC levels prove to be a good indicator in predicting the ovarian response to hormonal stimulation and pregnancy. They also help identify the decreased ovarian reserve at an early stage before it reaches the critical level. So keeping the same cutoff for both FSH and AFC, but making the AMH range stringent, this study found differences in the oocyte morphology in young women. So AMH proved to be a stronger marker of oocyte quality in young women, as the group displayed more changes in the cytoplasm, which studies show affect the embryo outcome and the implantation potential. Minor changes in the baseline FSH showed negative impact on the quality of the cytoplasm in the oocyte, though the patients were grouped as NOR. Women might exhibit poor prognosis even if the baseline FSH was less than, the cutoff was less than 10 micro-IU by ml. The results of the current study corroborates with the findings of Katz-Jaffe et al. In published paper in 2013, elevated aneuploid rates with decreased ovarian reserve. AMH, when it is less than 1 nanogram per ml, showed a greater proportion of aneuploidy of embryos, 66% with alterations versus 51.7% in the normal group. Alterations in the AMH levels reached higher aneuploid rates when it decreases. So decreased ovarian reserve in AFC category showed 2.9 times higher risk of having oocytes with altered shape, though the abnormality doesn't have significant effect on effect of the IVF outcomes. Alterations in the perivitellin space showed decrease in fertilization rates, 60.3 versus 37.5 when there are more abnormalities. Dosage of gonadotropin did not increase the morphological alterations in the oocytes, hence not affecting the oocyte quality. The limitations of the study is non-availability of dynamic or ecographic images and the lack of intra-observer reliability when assessing the AFCs because it was a single observer study. The sperm quality, though important in fertilization and embryonic development, was not considered, and hence the study did not consider fertilization rate and gestational outcomes. Further research is recommended in couples associated with more male factor infertility. And this study also suggests a prospective study with a larger number of patients to throw more insights into the outcomes and also the oocyte morphology. Take-home messages: AMH is a better marker to assess risk of both abnormal oocyte morphology and maturity. Baseline FSH alone is not critical when assessing the ovarian reserve. This study suggests that age alone does not reflect the oocyte quality because a correlation between age and the ART outcomes may not comply with patients with decreased ovarian reserve who are less than 35 years of age. Thorough investigation of the ovarian reserve could give clarity into optimal biological clock evaluation of an individual to become pregnant, especially in those with an increased risk of premature ovarian failure. Thank you for the opportunity.
Thank you, Rajpriya, for good presentations. Over to expert review, Dr. Sujata Madam.
Thank you, Tapisar, for the opportunity. Now, this is a very interesting paper. Priya had not mentioned, but this is an original article which was published in the Journal of Obstetrics Gynecological Sciences in 2021. And why did we choose this paper? Because, you know, like what was the common concept is there is always an age-related downturn of reproductive potential, and which is very well correlated with the oocyte quantity. And then involuntarily, we'll also, like associate oocyte quality along with the quantity. That is what the common thought is. But there are a lot of papers which says that if there is a decline in the oocyte quantity because of aging, then there is an association with oocyte quality also. But in other cases, say for example, for pathological reasons such as endometriosis or other ovarian surgery and things like that, where there is a reduction in the number of oocytes, the oocyte quality is not affected. This is what we have known. And in that paper which she had mentioned earlier, which actually, looked at some 5,000 and odd patients. It's a retrospective analysis though. And these women, they were less than 35. So aging is not a criteria there. Here they actually, divided it into two groups. One is a normal responder and one is a poor responder. And they showed that here actually, even if they get less number of oocytes, they still, had 44% pregnancy rate. Whereas in the normal responder, the success rate was 56%. There is a reduction, but still it does not say anything about the fecundity in those patients. But this paper actually says, irrespective of aging, when there is a decrease in the quantity, there is also a decline in the quality. So this is actually something which we have to kind of keep in mind, especially when we have patients who from whom we are expecting less number of oocytes. So it will help us in counseling the patient that what could be the expected chances of getting an embryo for transfer and what could be the expected success rate in these cases. And so this paper actually shows that there is a correlation, like whenever, even in women less than 35 years of age, if there is a reduction in the number, there can also be a reduction in the quality of the gametes. So that is the message what they have given. And another interesting factor which I got to know from this paper is, like, the risk of having immature oocyte is different if you are looking at AMH or FSH. I think we have to look at both these things together. Keeping in, taking these two parameters together, we have to expect what could be the percentage of immature oocyte, because this is something which we also see in our practice, that whenever we get less number of oocytes, we get lot of GVs and lot of M1s. And then what happens when a cohort has more of this immature oocyte, even with a good morphologically normal looking M2, there is a lot of degeneration post-ICSI. So I think this paper clearly tells us that there can be an association with the number, with the maturity of the oocytes. This actually will help us to fine-tune certain embryological parameters in the lab. Like say, for example, if we have to equilibrate the oocytes for a little longer time than normal, like if you are doing it for 2 hours in the regular cases, maybe you might have to do it for 3 hours or so to improve the maturity. And so I think that is the take-home message from this paper.
Thank you, ma'am. Thank you very much for your valuable inputs.
Thank you, ma'am. Sudhakar sir, you would like to add anything?
Okay, ma'am. Periodental space is more common in decreased ovarian reserve, no?
Which one?
Particularly.
Which one?
Sir is asking, is white perivitline space more common?
Space is
Are
common.
you saying more common?
I don't think so, because I think, like granularity is more, that is what we normally see more than perivitline space, this thing. And see, another thing which I forgot to mention was, see, they had mentioned about the subjectivity of AMH, but then there is also a lot of subjectivity in looking at oocyte morphology, because that is one of the major thing, like, and especially, see, perivitline space, a large perivitline space, it's still okay. Like almost 90% of the people will grade it the same. But this fragments or debris in perivitline space or granularity in cytoplasm, I think the grading is vastly different between embryologists. Even with the slightest granularity, some people will just say that granular cytoplasm. Some people only when it is very significant, when you see, like the deep central pitting, then you grade it as granularity. So this oocyte morphology grading is also very subjective. However, when you are getting less number of oocytes, I think the expectation should be, less, not like a patient where you have a lot of oocytes. That's the point we want to make.
Thank you, ma'am. Thank you, Rajapriya. That was a wonderful presentation, and thank you, ma'am, for all your inputs. The study mentioned that when the AMH is less than 1.2, and the results which showed that when the oocytes are retrieved, close to 23% of the oocytes are immature, and the trigger which they have used is only OVTRL. Where in this group of patients, a dual trigger will help improve maturity is one thing, which most of us are now switched on to dual trigger, especially in these group of patients. That's one thing. Another thing, when the FSH is less than 10, still it is an important message this paper is giving us is like still the oocyte quality can be poor in these group of patients is what we need to counsel the patients. So this is what I wanted to just ask
see,
and share.
this, they looked at patients who are less than 35. Like that is all the more significant there. And, see, when it is 35 for them, because we have a paper, right, from our country, which says that Indian women, they age much faster. So at least some 7 years, the difference is there. So I think all these things have to be kept in mind while we are stimulating the patient and while we are, doing the cycle in these patients.
Ma'am, I have a doubt, ma'am. Arulmozhi here. M2s, Sujata ma'am?
Yes, I can. Yeah.
The M2s, the oocyte abnormality, which is the abnormality which you are really paranoid when you see, or which will affect fertilization? There are a lot of oocyte morphology that you describe.
One is, large perivitline space. Now, when I say large perivitline space, something which is uniform across the ooplasm. Sometimes what happens is there will be a large perivitline space in one side only. The other side, it will be normal. Like the shape of the oocyte is a little bit ovoid. So because of that, there, on one side, you will see a large perivitline space. That may not have very serious implication, but if you have a perfect circular thing where you have equidistant, on all sides between the ooplasm and the zona, that is a problem. The second thing is very dark central pitting. Where even for ICSI, if you're not able to place the sperm in a decent cytoplasmic area, sometimes what happens is we have to go through the polar body itself straight so that you will not touch this central pitting because, it involves a lot of mitochondria and things like that. So that is also another serious this thing. But other than that, like any other parameter, see, the chances of fertilization, the chances of blastocyst formation might be less, but it is not, not nil. Still, you get blastocyst. In some cases, you still get good blastulation rate. In some cases, like you get pregnancy in the first attempt itself. So, like other things. And one more thing, maybe, like this dark brown zona pellucida, very kind of blackish brown, that actually can have. But otherwise, the other things, I think, see, it would depend upon the age of the patient. It would depend upon the sperm quality, all these things put together.
Thank you, ma'am.
Ma'am, I would like to add on the points for what you had suggested, ma'am. I came across a paper wherein the central granulation was highlighted, like SCR oocytes and also the ones with the centrally located granulation. The spindle length was found to be more than the normal oocytes. So that could also affect, isn't it, ma'am?
Having said that, we have a lot of immature oocytes in these group of women. What would be a strategy